One of the questions that comes up around the time of intubation is how much time do I have before this patient gets hypoxic? Here we are going to talk about the physiological variables that factor into this. We are not talking about the skill of the provider or the physical difficulties in airway secondary to anatomy. Avoiding hypoxia is very important, as once you start getting below SATs of around 93%, you are on a steep downslope and you don't have much time. So you want to intubate the patient while keeping their SATs somewhere between 90 to 100. As once you start hitting 90, you're on that steep downslope. So as you walk into a patient's room to intubate, you at least need to have a rough idea in your head about the time you have to intubate this patient. The key rule is for oxygen to be picked up in the lungs. As long as there is blood flowing through the pulmonary capillaries and you have an alveolus that is open, you are going to have gas exchange. When we paralyze a patient to intubate, there is still air left in the patient's lungs, and that volume is called the functional residual capacity. So these are the various lung volumes that we all learned in medical school. But functional residual capacity is a combination of the expiratory reserve volume, that is, at the end of a normal breath, if you force yourself, you can still expel some air, that is the expiratory reserve volume. And there's going to be air that you can never expel no matter how much force you use, that is called the residual volume. The combination of these two is called functional residual capacity. So when you paralyze someone to intubate, or when they stop breathing because you sedated them heavily, the volume that's left in the lung is the FRC. So for you to understand how much time we have to intubate a patient, we need to know what is the normal oxygen consumption rate. It's around 250 cc's per minute. Functional residual capacity in a 70 kg, a 6-foot individual is 3500 cc's. If you're on room air, 21% of this is oxygen. A lot of this math that I'm going to use here are approximate, they are not accurate. This is just for you to get an idea of doing the math in your head. The goal here is not to be exact. So with an FRC of 3500 cc's, 21% of it being oxygen, it's roughly around 700 cc's or so. And you are consuming at 250 cc's per minute. So you have roughly a little over 2 minutes in theory before you get hypoxic. It's actually much less than that, because as you consume the oxygen that is in your FRC, your alveolar partial pressure of oxygen goes down, so it's harder for it to diffuse and dissolve in the plasma water. So somewhere around a minute to minute and a half, you start getting hypoxic. What will happen if we use 100% oxygen by doing bag mask ventilation and denitrogenating this patient? Now the entire 3500 cc's is going to be pure oxygen. So you're consuming at 250 cc's per minute. So the rough math will be around 13 to 14 minutes. And you got all the time to intubate. That's why it's key that you have to bag mask ventilate the patient or pre-oxygenate them using a non-rebreather to fill their lungs fully with oxygen. This is not particularly applicable to around intubation, But another concept that we need to understand is what is called apneic oxygenation. Let's say you intubated a patient and you connected them to an oxygen source. There is no ventilator in between. That means the patient has access to pure oxygen, but he is not breathing. How long will it take for this patient to get hypoxic? In fact, it is a lot more than 14 minutes. If you see this particular graph, if you put a patient on 100% and put in a closed circuit, even if they are paralyzed, it may take more than 2 to 3 hours for them to get profoundly hypoxic. Why is that? This is due to the difference between the solubility of oxygen and carbon dioxide and also the respiratory quotient. So let's talk about the solubility of oxygen and carbon dioxide first. CO2 is far more soluble in plasma water than oxygen. So when you are paralyzed, not breathing, as the partial pressure of CO2 starts going up, it dissolves more and more into your plasma water. So the body's ability to buffer CO2 is also much higher, so it will absorb a lot more CO2. That means the CO2, instead of entering into the alveolus right away, kind of gets stored inside your body, like you're becoming like a bottle of soda, essentially getting fizzy. But eventually you are going to rise the PCO2 so high that it will start displacing oxygen in the alveolus. That's why with severe hypercarbia, eventually you will get hypoxic, even if you're on 100% oxygen. Essentially, there is a limit to how much gas you can put into a soda can. So once you cross that limit, you're going to start filling up your alveolus with too much CO2 and it displaces the oxygen, leading to hypoxia. The other part is the respiratory quotient. So for every 5 molecules of oxygen we breathe in, we only put back 4 molecules of CO2. So there is actually a gradient of pressure that will let you move oxygen towards the alveolus even at rest. The combination of these two, where the solubility of CO2 being very high and also the respiratory quotient being 0.8, allows you to oxygenate a patient without actually ventilating them. Ventilation is moving air in and out. That's your normal breath. This is the concept behind apneic oxygenation. So when you have an ET tube already in the patient and connected to a source of oxygen and they are paralyzed, you will still move oxygen. In fact, the pressure inside the alveolus is subatmospheric because oxygen is being consumed and it is not being fully replaced by CO2, so it creates a gradient for the oxygen to move towards the alveolus. This concept is used in clinical scenarios usually in 2 situations. One is apneic oxygenation. Let's say somebody has high flow on them, you bag mask ventilated them and you're getting ready to intubate the patient. Don't take that high flow out because you can use apneic oxygenation to increase the time you have available to intubate the patient. Remember, when you have high flow nasal cannula, this is not a closed circuit, so you don't have these 2-3 hours that we talked about. The second instance is brain death testing. When we take patients off the ventilator, we put a cannula into the ET tube and put some oxygen through it while we wait for the CO2 to rise. Essentially, you're trying to avoid hypoxia and let the patient become hypercarbic to show that despite hypercarbia, patient is not breathing, indicating a brain death. So important to understand the concept of apneic oxygenation. But the most important part you have to remember is bag mask ventilation. This is your friend. Whenever a patient goes hypoxic, if you can bag mask ventilate the patient, please go ahead and bag mask ventilate them and get the sats as high as you can. Don't just restart your attempt right at 93. You want to take them all the way to 100% saturation because you are still denitrogenating. Roughly 12 breaths should denitrogenated as long as they are high volume. And then reattempt because you're resetting the clock for hypoxia. And also, we have to remember our patients are not your ideal 70 kg individual and 6 foot. If you are morbidly obese, your BMI can go, morbidly obese, your FRC can go much lower, even at rest. In normal people who are walking around, but their BMI is like 50, 60, their FRC may only be 1,000, not 3,500. So mentally adjust for that when you see a morbidly obese person. And also while you're intubating, keep the patient sitting up or 45 degrees ramped up so that you do not crush their FRC by laying them flat and letting their abdominal viscera push up the diaphragm and decrease the FRC. The same physiology applies to pregnancy, but also you have to remember the oxygen consumption is going to be more than 250 cc's per minute in pregnancy. And also infants tend to have a higher metabolic rate relative to their FRC. So kids will get hypoxic sooner than adults. And anyone who is septic, has fever, will have a higher metabolic rate and oxygen consumption. So what is a nightmare scenario? You have a morbidly obese person who you lay flat in the setting of ARDS with lungs looking like this, where there is decreased compliance and they already de-recruited. There is hardly any FRC. And these patients will go hypoxic on you in no time. So the ideal 70 kg individual is not what you'll be dealing with in clinical practice. So as you walk into that room, just mentally go through this. Is my patient obese? What do I think their oxygen consumption rate is going to be? And how do their lungs look? So that you can optimize your success at intubation. Avoid hypoxia. Once you get hypoxic, you're entering into what is called the circle of death. That will be discussed in another video.